Watchman implant procedure in a patient with a difficult transseptal puncture using transesophageal echo and intracardiac echocardiography to evaluate the left atrial appendage, ruling out intracardiac thrombus, and do the measurements of the left atrial appendage. Then obtaining vascular access, usually using right femoral vein, in order to insert and then advance transseptal sheath and needle. At this point, SLO sheath and BRK needle have been advanced over a wire to the SVC, and they are ready to drop to the interatrial septum for transseptal puncture. In this case, intracardiac echocardiography in the right lower part of the screen, transesophageal echocardiography under the left upper part of the screen, and fluoroscopy in the right upper part of the screen are used as the guidance in imaging for transseptal puncture. Transseptal sheath and needle here were dragged down from SVC to the interatrial septum, and the tenting of the sheath over the interatrial septum can be seen on the intracardiac echocardiogram on the right lower part of the screen. As it can be seen in the intracardiac echo imaging, the septum is extremely thick. This is a cardiac anomaly called lipomatous hypertrophy of atrial septum. Because of the thickness of the interatrial septum, the needle cannot pass through the septum, and we are using electrocautery, and even then, it is very difficult to make an effective puncture. Here we switch our imaging modalities from intracardiac echo to transesophageal echo to reevaluate the position and location of our transseptal puncture. Switching back to intracardiac echocardiography, we finished our transseptal puncture mostly using intracardiac echo. After performing transseptal puncture, weight-based heparin was given, trying to keep the ACT between 300 and 350, and super stiff amplatz wire inserted to the left superior pulmonary vein, and the SLO sheet was tried to be exchanged to the Watchman sheet over this wire. Here, Watchman sheath was advanced to the interatrial septum over that wire. However, you will see that because of the lipomatous of the septum and its unusual thickness, it is not possible to advance the bigger sheath, Watchman sheath, over the wire to the left atrium. An excessive amount of push and pressure here can be dangerous with a jump to the left atrium and potential perforation. Here we exchange the super stiff amplats wire to the Baylis pigtail wire. This is considered to be a safer wire because it is a pigtail type of a wire, and a little bit more push and pressure can be applied in a more safe way. Nevertheless, we could not advance the Watchman sheath to the left atrium safely. Here, one option could be using long dilators and gradually dilating the transseptal puncture. However, the most effective and the safest way to deal with this kind of a very thick interatrial septum is septostomy, which is basically a balloon angioplasty of the transseptal puncture. Here we remove Watchman sheath. We keep the pigtail Baylis wire in the left atrium. And then I used here a 16 French sheath, just a regular sheath, through which over that wire we're going to advance a peripheral vascular angioplasty balloon. Choosing an appropriate size of the balloon itself can be an interesting discussion. Since the Watchman sheath is 14 French, the balloon should be at least 5 millimeter in size or bigger. A bigger size can be chosen for very thick septum and when we decide to use lower atmosphere pressure during the inflation of the balloon. In this procedure, because of very thick septum, we used a 8 millimeter balloon and we inflated the balloon to a subnominal pressure. Here, balloon is advanced to the septum and then it's inflated to dilate the transseptal puncture. Depending on the thickness of the septum, sometimes we may have to repeat this septostomy technique a few times. Now a Watchman sheath can be relatively easily passed through this dilated transseptal puncture site. Inserting pigtail catheter through the transseptal, through the Watchman sheath into the left atrium, and then advancing that under TEE guidance as well as fluoroscopy RAO caudal view to the left atrial appendage. Here, injecting contrast into the left atrial appendage through the pigtail catheter give us the fluoroscopy view on the right upper part of the screen of the left atrial appendage, and the final measurements and is done here on fluoroscopy to decide about the size of the Watchman device. Here, appropriate size Watchman device, in this particular case 24 millimeter device, is prepped and then advanced through the sheath into the appendage, and then repeat imaging by contrast is done to confirm our position and making sure that we had not moved from the position. Here is deploying the Watchman device under fluoroscopy. On the right upper corner of the screen, you can see that the technique, depending on the anatomy and the situation, can be a combination of de-sheathing or pulling the sheath back, or advancing the device. The details of it depends on a lot of anatomical detail and the device size, etc. In this case, you see a combination of pull and push and advancing the Watchman device into the left atrial appendage. We then here evaluate the device by both transesophageal echo and fluoroscopy in terms of adequate compression, adequate form and shape, also the torque test, making sure the device is sitting safely and tightly. This is our torque test. Contrast injection into the appendage. A second contrast injection in a little bit different fluoroscopic view. Here, the device is released, and we are checking for ruling out any pericardial effusion by transesophageal echo. Final position of the device looks very good on both transesophageal echo and fluoroscopy. Sheath were removed from the groin, and hemostasis was achieved by using Periclose system in this procedure.